This is a case study on a colonic obstruction from CHS Lincoln on September 7th through the 20th. So the outline, I'm just going to kind of go over the literature about colonic obstructions, and then I'll just go through the nutrition care process. So a large bowel obstruction occurs when a blockage is in the colon or the rectum, and this prevents food or gas from passing. So you can see this happens all right through in here in that large part of the intestine. The intestine begins to swell. If the blockage in the swelling becomes too severe, the bowel can rupture, can perforate, blood supply to that tissue, so to the tissue surrounding here, can be cut off, and then the bowel can eventually die. Some cause and some risk factors for a colonic bowel obstruction: previous abdominal surgery, colon cancer, inflammatory bowel disease, especially fecal impaction, diverticulitis, previous abdominal trauma, hernias, or a twist in the bowel, because that twist would make a blockage and then lead to a tissue death. Symptoms of a large bowel obstruction are not being able to pass gas, not being able to have a bowel movement, going a long time without having a bowel movement, nausea, vomiting, abdominal bloating and swelling, and abdominal pain. And usually it's crampy and it's around that area where the bowel is obstructed because the bowel is trying to contract to push it through. So if you have a large bowel obstruction, the situation can become emergent, and an emergent solution for ischemic colitis, which is what happens in a bowel obstruction, is the Hartmann procedure. The Hartmann procedure is shown here, and the goal is resection of the dead, infected part of the bowel, and to divide the bowel where there is still good, healthy blood supply. This results in an ostomy bag, and in this case, it's an ileostomy. So the patient is Miss Suit. She is a 54-year-old white female who is engaged with adult children. She is unemployed. She has filed for disability, has Medicaid, and she was in the critical care unit at CHS Lincoln, which is not a very big unit. We call our ICU critical care, and there's 10 beds. So her medical and surgical past history: she has an extensive history of lung problems. She is a heavy 1-pack per day smoker with COPD. She had a history of small lung cancer. She was receiving care outside of our healthcare system in Gastonia, but her family reported that it was under remission. She has hypertension, overactive bladder. The power port was for her cancer treatment, and she also has chronic back pain. So she has chronic back pain and is on, you will see subsequently, a lot of medications for pain, which, as we know, can cause constipation. She is 68 inches tall. She is obese. We're saying that she weighed about 198 pounds. Her weight fluctuated, so we use the clinical nutrition weight, which is the dosing weight that all of the medications are based on, because weights can change and fluctuate so often in the hospital setting, and by the way that the weight is obtained. Her estimated energy requirements are based on the Aspen 2016 critical care guidelines. Miss Suit was in the ICU, and with that BMI of 30.1, she qualifies for these care guidelines here on the right. So obesity, vent or no vent, it said that 11 to 14 kcals per kilogram actual body weight with that BMI being 30 to 50. So she falls in that category. It's very important that she gets plenty of protein because of this surgery that she underwent, because of the increased need for protein for wound healing, for fighting infections. But the guideline is to estimate it by ideal body weight, so 2 grams protein for that. And that feeds be held at 10 milliliters per hour, and they should be tropically fed, so dripped, at a rate of 10 milliliters per hour for people on multiple pressors or if they're on septic. So using all of those guidelines, I calculated her estimated energy requirements shown on the left. So she needs 993 to 1264 kcals. Her protein needs are high, 128 grams per day. She didn't have any troubles with diabetes before, so we just did 50% of the cals, and a fluid to kind of meet that energy need. Prior to admission, she was on a lot of medications for the COPD. So she was on a lot of bronchodilators, short-acting, long-acting, a corticosteroid to help with inflammation. She was on some diuretics and some hypertension medications. She was on Lasix. She was on levothyroxine, which is important that you take an hour before eating. But what I want to really kind of focus on is the fact that she was on benzos. She was on corticosteroids that could cause weight gain. Zofran can cause constipation as well. And so she was kind of taking all of this medication in conjunction with some complaints of chronic constipation in life. And so that's kind of how she ended up at our emergency room. So the critical care guideline applies kind of into this timeline of her care. So on the 7th, she presented to the ER with left side lower abdominal pain right in that large intestine. She had come to the ER 2 weeks prior with the same complaint, but was diagnosed with having colitis, and she was discharged with a course of antibiotics, Cipro and Flagyl. The patient reports that she had been taking the antibiotic, but she hadn't had a bowel movement in 2 weeks. So she was constipated, and she was admitted for a leukocytosis and a colonic bowel obstruction. In the morning, she had shortness of breath, trouble breathing. Her stomach was markedly distended. They said that she looked like she was pregnant, like months pregnant. They did enemas. They tried to get that obstruction cleared with no significant bowel movement, and it was decided that she was going to have a colostomy. The next day, she was transferred to the critical care unit because her abdomen became even more distended. She went under respiratory distress, became hypoxic. She was emergently intubated, and she was septic. Her lactic acid was 3.3. So then she has this Hartman procedure shown before. They found that her colon was massively distended with patches of gangrene and perforation, and that it was really foully smelling. The surgeon notes that, so she had a subtotal colectomy from distal ileostomy to mid-sigmoid colon. So that's what they took out. She has returned to the CCU on pressors, and was hypoxic and remained intubated. She was still in septic shock, and they identified the source of that perforation in the abdomen. They did not start nutrition right away, but the surgeon assessed that everything was going fine, not to wean her from the vent, await the evidence of the bowel function. And then the next day they saw that, so they started to wean the pressors, and we started tube feeds at a low rate to stimulate the gut. She was eventually extubated. She went on BiPAP because she was still struggling a little bit. So BiPAP is a different form of intubation. BiPAP and CPAP and vent, it all is kind of like a fluid. Nasal cannula is in there too. So she was not able to breathe room air on her own at this point. The surgeon spoke with the family about what their goals of care were. She was struggling. She was back on the BiPAP. They talked about if she needed to be re-intubated, if they wanted to do that and such. But the next day, she kind of pulled through. She was alert, oriented, interacting. She wanted to eat. She wanted to have something to drink. She was improved from that BiPAP the day before. But the surgeon notes that the patient is struggling to breathe. Was on 3 liters nasal cannula, and the surgeon thought she might wear out. So with that history of COPD and that lung distress, she was having a very hard time coming off of the vent and coming off of this assisted intubation. So the next day, VCC, so that's virtual care, the physician was called because she was hypoxic again. She was having struggling to breathe, so she was emergently re-intubated. And there was notes that she had volume overload and underlying diastolic dysfunction. So she was starting to retain all of this fluid. Her white blood cells began to go back up. She had a fever. Luckily, the NG tube was still in through this whole time, so they didn't have to re-put in a DOP off, so we were okay there. And then palliative care worked closely with the family at this point, and the patient became a DNR. So all the way up until then, she was a full code blued, and she became a DNR. So the family decided that after the second round of intubation, if she was extubated, they didn't want to go for a third. They did not want to peg or trach at this time. And so the goals of care switched a little bit. The patient continues to be intubated and sedated. There's no acutes of overnight problems, and she was still having troubles balancing her electrolytes. On the 15th, the physician consulted with the RDs, and we made some changes in her enteral feeding route. So when it became clear that she was being re-intubated, we switched her feedings to NG, enteral feeds, as well as TPN. So the physician met with the dietitian, and we determined that we were not going to be able to meet her needs solely based on the enteral nutrition, and we were not able to progress to goal rate because that bowel wasn't ready yet. And she was put back on pressors. So it was just so much that we were unable to, we had to kind of have a good balance. So on the 16th and on, the patient still becomes very sick. She has a fever. Her wound had to be debrided. So she had this big midline abdominal wound, and she had a wound vac on this whole time because of that emergent surgery. It wasn't laparoscopic, so that she was fully opened. The surgeon sees the patient on the 19th, but things are starting to work. There's stool in the bag. She's starting to heal a little bit. This midline wound is doing a lot better, and they've determined that this patient needs long-term acute care, so to go to an LTAC unit to wean. So she wasn't going to be able to do it immediately and do these spontaneous breathing trials to come off that vent in our critical care setting. So on the 20th, the doctor met with the family and they discussed the plan of care, and we kind of switched back. The family decided that they were going to go to the LTAC if she needed to be pegged and trached, that they were going to do that. So they changed their mind, and now they are not interested in pursuing comfort measures, and they agree with a great aggressive treatment. And that is treatment that she could receive there. So on the 20th, she was transferred from our critical care unit to the LTAC in Kings Mountain for extended care and rehabilitation. So these are her laboratory values through her time there. You can see that her white blood cells are high, and there's another chart coming up. They are high this whole time, but she was okay. Her bun is very elevated here. Her glucose was kind of all over the place, and her GFR starts to decrease for a little bit. So the patient having this struggle with fighting this infection in these first couple days, and then on the 12th, you notice this is when they notice all of that fluid on the patient. And so you can tell that she had a ton of fluid. Her blood indicating values, so her red blood cells, hemoglobin, and her hematocrit are decreasing. Her sodium is elevated. Her bun is elevated. Her creatinine had come back down, but her kidney function changes, and then it continues to get a little bit worse. So she's having a decreased GFR here. Her red blood cells, white blood cells, hematocrit are still low. And then her GFR becomes low. So she's having so much fluid on her that her kidneys aren't able to process it like it should. And they had started to administer albumin to help with that fluid and to try to prevent her from third spacing. Her triglycerides were high. They were okay on the 13th, and that's right around when we started, close to when we started TPN. We started on the 15th, and then we're monitoring it because when the patient is on TPN and receiving propofol, we have to make sure that those triglycerides don't go too high. So she was on all of these medications. Of course, there's a lot for pain. There's a lot for breathing. There's stuff to fight infection and antibiotics. But I wanted to focus on a couple in a minute. So when I said that she was third spacing, so what this means is when the fluid in this body is moving out of the intravascular space to the interstitial space. So that's moving out of that into the space in between the cells. And it's not supposed to do that. So the volume overload can lead to peripheral edema, pulmonary edema, a decreased cardiac output, hypertension, renal dysfunction, and we were seeing all of that starting to occur. Human albumin helps with that shift, and so that is part of the reason they started supplementing and giving Miss Suit this human albumin replacement. So the pertinent inpatient medications I wanted to focus on was that albumin, the fact that she was getting insulin to regulate her blood sugar, especially being on TPN, that'll increase your blood sugar values as well. That in conjunction with prednisone, methylprednisone, increases that blood glucose level. She was on pressors off and on, so that's why our feeds stayed low and that we tropically fed. She was on Lasix to try to help with that volume overload as well. This is a chart that I made. It shows that her POC blood glucose levels, so her finger stick values, over her entire stay with us. This red line indicates a blood glucose level of 179. And so in the critical care, we strive to have blood glucose at 179 or below, because that helps with healing. It keeps the patient is able to become more stable, and that is something that we strive for. So with that Levemir, the Humalog, the regular insulin, they were trying to manage it, but you can see with that source of infection, the fever, the prednisone, the TPN, that she was kind of all over the place. So Ms. Soot was nutritionally diagnosed with an altered GI function related to this acute chronic illness, with an alteration in her GI structure and function, as evidenced by that Hartmann procedure resulting in the ileostomy. She had an increased nutrient need related to chronic illness and surgery, evidenced by that increase in protein for healing and infection. And she had a self-feeding difficulty related to the intubation status, as evidenced by needing parenteral and enteral nutrition to meet her estimated energy requirements. So how did we intervene? So in the beginning, after the surgery, once the surgeon cleared for drip feeds to stimulate the gut, before she was weaned in the beginning, we said to initiate just enteral nutrition. I chose Vital High Protein so we could try to meet that 128 grams of protein requirement that she needed. So Vital High Protein running at 50 milliliters an hour with a 20 milliliter hour flush was to provide 2,000 calories, 105 grams of protein, 134 grams of carbohydrate, and 1,483 milliliters of water. In addition, this was only providing 1,000 kcals. In addition, or 1,200, I'm sorry, we provided 1 packet of ProSource per day to give us an extra 100 calories and 15 grams of protein. And so that is just a gel that is added into the tube. And so this got us up to 120 grams of protein, which was close to that 128 goal. So this ran at 10 for 3 days, and then she had to become re-intubated. So once she was re-intubated, we ran the TPN and the enteral nutrition. So we switched to Vital 1.5 from the Vital High Protein to provide 360 calories, 16 grams of protein, carb, fluid, so on, it's listed. And then we switched and we did 15% amino acid, 5% amino acid, 15% dextrose without electrolytes at a goal of 40. So this TPN plus the enteral nutrition got close to her estimated energy needs. And this is what she was discharged at. She was not receiving electrolytes in her TPN because of that big fluid imbalance and the fact that she was having a hard time functioning and managing her own electrolytes. The doctor at this point managed her fluid and her electrolytes. So she was on an electrolyte protocol saying if her potassium came back low, for example, the nurse was able to give her a rider and just push potassium. So we weren't having to constantly call and say, hey, the labs came back this morning and they're low. Can you please supplement? So with all of those interventions or all of those diagnoses, our interventions kind of fit in to kind of meet and address those problems. And so the altered GI function, she was NPO for healing and the patient was intubated and we did minimal feeds. The that NG tube and central line was placed, the fluids were managed by the doctor, and we wanted to make sure that she didn't have any high residuals. For the protein, we chose a high protein formula. She had plenty of protein from the TPN, and we also provided that ProSource in the beginning to add extra protein. This helped the wound healing, the ability to fight the infection, minimize an inflammatory response. The self-feeding difficulty, she had the enteral and parenteral feeds that met that problem. In addition to that, it should be noted that we did not do any intravenous fat emulsions. The patient was on propofol the whole time, and so with propofol, it's administered in a fat emulsion. So with her propofol, she was getting plenty of calories, on some days up to 600 calories just from propofol. So that addition to the TPN and the enteral nutrition, we were close in meeting her needs as well. That propofol is 1.1 kcals per milligram. So, it really just adds up, and especially when they're in so much pain and having to be so sedated, there is no risk for fat to go into an amino acid fatty acid deficiency. So we monitored her gastric residuals. We wanted her that weight because there was such a big shift. And with the MD, we monitored the electrolyte balance and her hydration status. We wanted to see that there was formula tolerance, that there was GI tolerance, that she did well with the regimen, and that she started to have that wound to heal. So towards the end, the surgeon noted that there was minimal drainage. It wasn't as red. It was starting to close. And so, that protein was working. So the patient was discharged from our care to Kings Mountain LTAC. But one of our dietitians in our care team, that's under my preceptor, she also manages LTAC. And I've spoken with Tony, and the patient is still alive. She's extubated, she's up eating, she's starting to heal. Of course, it's going to be a slow healing process. And with that COPD, she's, it took a longer time to be extubated, but she's doing well and she's more stable. And so our interventions, in a sense, worked. We were able to get her weaned. She ate on her own eventually. We stabilized her at our facility and for the ability to be transferred. So in this case, the nutrition intervention worked. She was eventually weaned from the vent. There was a very strong interdisciplinary team approach to this case. We worked very closely with the doctors and with palliative care and the nursing, and we were constantly on the phone. We were able to go down there. We were able to talk to the family and help them understand their goals of care and how nutrition fit into that. And I think, especially in the critical care setting, that this is very important that these strong team approaches continue to happen. And those are the references that you all have access to.